Hey everybody, I'm your four-eyed professor, Chris Lievens, and I'm super excited to talk to you today. Our roll call is for new and experienced ODs, optometry students, and even those just interested in this profession. We'll cover a number of topics together, and I'll help you see them through a professor's eyes. Please take your seats. School's in session. Welcome back, everybody. Thanks for joining the podcast today. We are going to continue our in-depth look at Heidelberg Engineering's Spectralis instrumentation. And I have a guest that's been on the podcast before, Dr. Drew Rixon, VA optometrist, who has a lot of experience managing and treating and identifying ocular disease, as well as has a lot of hands-on experience with the Spectralis. And the topic today is going to look at how sometimes we get confused and misled by images, and how if we're purposeful and we're looking at scans in a very specific manner, then maybe we can avoid some of that confusion. Some of the things that show up to us at times are red, which suggest abnormality, and green, which suggests normalcy, and that's just not always the case. So let me bring to stage, hey, Drew, thanks for joining us.
Hey, Chris, thanks for having me back, man. Really appreciate it. Looking forward to talking red and green.
This is a really important topic. And now with OCT technology really being a standard assessment on lots of patients, this is just a topic that I think will resonate with a whole lot of people.
Yeah, undoubtedly. I mean, it is kind of the preeminent way to look at glaucoma these days. It's definitely shifted a ton.
So let's start there. So we have a glaucoma patient, and it really doesn't matter whether it's a new diagnosis or an established patient that we're looking for progression in. When you are looking at your computer display, or for that matter, a two-dimensional piece of paper, where do your eyes go first? You know, what do you do to first question, okay, is this good data or maybe not good data?
Yeah, I think to me, the first thing I'm going to do, at least with Heidelberg, is I have a display screen. So I'm actually trying to look at the raw data on the actual, like as if I'm actually down on the machine looking at it. I'm trying to look at the tissue, right? So in the tomogram up and to the right, or like depending on where you displayed on the two-dimensional, like the paper scan or whatever's populated into Forum or however you're doing it, I'm trying to look at the segmentation first. So I'm looking at, what's the reflectivity? Is it crisp? Is the scan of good quality? And, specifically we're talking, I guess, to start with, the OCT, the RNFL, I'm looking to see, is it actually capturing the tissue that it's supposed to be capturing? And are there any problems within that could potentially impact my line of thought? And I think I've had a huge transition there from early OCTs where all you're getting is the printout, and you're literally just looking at that Tisnet curve and you're like, okay, that's pretty decent. Right. And I think we need to be a lot more sophisticated, but we don't need to overcomplicate either.
Yeah, I'm glad you mentioned that, because we really have evolved in that. And I would say most practices today do have access to their OCT instrument at their computer terminal as if they were sitting right in front of the instrument. But not too long ago, we didn't have any of that. Addition, you were talking about looking at the tomograph and its crispness, and not too long ago, none of them were crisp.
Yeah.
And so, now we see things with far more detail than we ever could before. So in that vein, when you're looking at any slice and you're taking your mouse and you're scrolling through images, what flags might catch your attention to say, maybe we ought to run this scan again?
Yeah, I think the number one thing is looking at centration, whether it be, laterally or whether it be vertically, as far as just a starting place. Like, are we even capturing it where we think we're capturing it? And then really anything, because it's OCT, right? It's optical. So you're dealing with light. So really anything that's disruptive as far as getting from the environment, front of the eye, rather, to the back of the eye, vitreous, and then you have other things, ERM, tear film can play a role. So I think to me, it's just like, you can look at the quality metrics numerically, which I think have some value, but I think you have to be able to look at it with your own eyes and see. So, tear film, vitreous, and you'll see shadowing, or you'll see areas that are cut off, laterally or vertically. And, you can see the machine does everything that it can to try to smooth things out, to try to render a really nice image for you. I think that can be really misleading.
So if you have a glaucoma patient in your chair and you've done a number, or your technician has ran a number of scans, what's the first thing you're gravitating to? Are you going to a nerve fiber layer thickness or something else?
Yeah, I mean, to me, I think it still comes down to like context, right? So I think if we're not doing screening testing, which most of us aren't, and we're doing, I guess, targeted testing, we should already have some clue just based on our clinical assessment of the nerve. So, you or I are we're gonna look in there. We're gonna look, with our non-fundoscopic lens, like a 66, or is usually what I use. And you're gonna go ahead and look at the rim, and you're gonna say, okay, so I think I have, superior rim erosion, and the OCT should be used almost as a confirmatory device, right? So I'm going to gravitate towards confirmation of what I already think I'm going to see. And that's probably going to be an RNFL thing first, because I'm not going to clinically be able to determine that there's thinning in the isolated GCL. I mean, we're not good enough as humans to pull that off. So I'm going to gravitate first to the segmentation scan, then looking actually on the segmentation scan for diminished tissue before I'm even getting over to the red, the green, the patterns, any of that stuff. Is it a glaucomatous defect? Do you have a wider, more diffuse change? Do you have a focal, degradation in the RNFL, or is it something else? Because I think a lot of times when we do these OCT RNFL scans, a lot of times you'll say, "Whoa, wait a second, I have elevation of RPE, I have a parapapillary net or something." But yeah, for me, that I'm pretty much gravitating to RNFL first, specifically the segmentation.
So let me ask you this, because you said look at the anatomy first, look at the patient first, everything there, and then make your OCT technology, in this case Spectralis, a confirmatory position for you. Those listening who aren't as gray as you and I are, Drew, who didn't, we started when there was no such thing as OCT technology. And so that's very natural. Do you think practitioners do it the same way today, or do they look at the OCT before they even see the eye?
Yeah, it's actually a really good question. I think that there's a tendency to do wellness scans across the board. I think there's definitely value, efficiency, and I think specifically just discussing things with patients. I have a colleague that does a lot of remote care, and they run the patient through pretty much every technology, and the patients love it, because you think of just how everybody's gravitated towards technology. You seem to be a lot more avant-garde when you're doing that versus the traditional, stepwise approach, dilate, then be kind of retrospective on it. So if you are going proactively, then you really got to be careful to be very discerning as far as what your interpretation is. I think because we grew up without OCT, it's forced us, I think, to be, number one, skeptical, but it's forced us to learn the language from the ground up. Whereas, if you already have OCT, maybe you take for granted just looking at a scan and just kind of thin slicing it from a vantage point. So I just do a quick thin slice. I'm done. Patient has this, patient doesn't have this. But I think that can lead to a lot of misdiagnosis, especially with the wellness scans. And you misdiagnose off poor interpretation, you're condemning a person to a lifetime of a disease that they might believe could blind them. And I don't think that's probably in our best interest or the patient's best interest to behave like that.
Yeah, no doubt whatsoever. And we're going to get to that topic later anyway, because, misdiagnosing a patient, calling it something that they don't have might put them at a lifetime on a treatment plan and frequent follow-up that they don't need. And then obviously missing the diagnosis entirely. Well, now you're letting something exacerbating get worse under your watch. And so neither one of those scenarios is optimal. I mean,
Absolutely.
You mentioned something that's a little bit off topic, but I think is critical for our listeners, and that is you gravitate towards a 66 diopter lens for your glaucoma patients. And what I think a lot of people don't understand optically is when you're doing fundoscopy, um, if you have, let's say, a 90 diopter lens and you alter the magnification on the slit lamp itself, the biomicroscope itself, compared to keeping the mag the same but altering your dioptric power of the fundus lens, the optics in the latter scenario are far better and far clearer. And so if you find yourself in a large glaucoma practice with lots of glaucoma eyes like you are, a 66, a 60 is going to give you a whole lot more clarity than a 90 or 78 by just altering the mag on the slit lamp. Would you agree?
Yep. Yeah, completely. And I think the other thing for me is, it's your first day with new third years. I had my first day with new third years over at SCO yesterday. It's constantly trying to reframe. And I think, that Forge years ago was trying to reframe how we're looking at the nerves. And so to me, using a 66 allows me to try to get an idea, because the mag is 1-to-1. If I'm looking at the vertical height, it's given perspective. So usually I say, well, I say, how big is the nerve? And the student says a 0.6. And I said, let me rephrase this as, how big is the nerve? It's a 0.6. I said, no, I didn't ask you what the CD was. I want to know how big the nerve is, because it provides context. And I can at least get some perspective if I'm using the 66 and just measuring, oh, okay. And I'm not saying we need to be super specific, but is that nerve large? Does the CD make sense for that nerve? Or is it small? And it's just reframing how we're looking at things. So I really do think just having a mag where I don't have to think, where, you go with the 90 and they're like, oh, you got to multiply times 1.3. Is anyone actually doing that?
No, I don't think so.
I mean, God bless if they are. I've tried before, but it's just providing perspective. So absolutely, I like the clarity. And a lot of people really like that digital high mag as well.
Mm-hmm. Yep, agreed. All right, so you've got your Spectralis scan on your platform in front of you. You've said, all right, I'm not alarmed by segmentation errors. I understand the issues between the vitreous, the retina, the vitreous, the macula, the vitreous, and the nerve head. I understand what else is going on in the retina. I feel pretty confident that this is a good image that now I can look at, and it's reliable. What do you do next?
Yeah, what do you do next? Did it corroborate the information that you thought it was clinically, again, coming from our perspective? And then, I've now looked at RNFL, so I have that piece of information. And what else is damaged when you have glaucoma? Well, primarily, if you think about where the axons derive from, they're derived from the ganglion cells. So I'm going to go ahead and look at the macular data at that point too. And I'm going to want to make sure that that is of good quality and the segmentation is good there too. And I'm going to try to put the RNFL and the macular data together. And then I'm going to try to look at everything topographically. So what I would tell you is, if all we're doing is looking at just the RNFL and say we have a superior temporal defect, which we thought aligned with our rim erosion that we saw clinically, are we comfortable overall that we have an arcuate that is truly glaucomatous, and are we omitting information? That's where you go to the macula. And so you put all that stuff together. If you have a topographically consistent defect that is glaucomatous, then that's pretty darn confirmatory overall for you.
Obviously, patient A from patient B is going to differ a little bit, but do you think that your macular or ganglion scans, if they have issues, are preceding nerve fiber layer issues? Or do you think these things are presenting simultaneously?
Yeah, that's a great question. I don't know that that's actually been teased out in the literature as far as which comes first. I mean, theoretically, what's that?
Yeah, I'm just asking you what you think.
Yeah, I mean, it would seem reasonable that you would be able to detect at the same rate relative to the sophistication of the technology, right? So, I mean, obviously at the cellular level, the ganglion cell's dying, right? And then, I mean, there's some studies out that lamina comes first too, with like adaptive optics, stuff we don't have in our practice. So you would think that those should be occurring relatively at the same time, or at least if there's any sort of a difference in the time frame as far as the color map or the topographical change, it wouldn't be so disparate that you wouldn't be able to tell. I would think it would be a line there. And I think I'm somewhat accurate on my science there.
Okay. All right, so now I want to dive in a little bit into the context for this episode, in that when OCT technology came out and we started looking at paper printouts, quite different than visual field printouts when these were the first to come in color. And so right out of the gate, immediately, we had a stoplight presentation of abnormality, where we have green on the printout indicating and suggesting good, yellow is a question mark, and red suggesting abnormal, when in reality, these colors are indicative of percentages of likelihood of issues compared to the normative database in the system across manufacturers. So I wish we didn't have that, because I don't know about your eyes, but my eyes immediately go to color, because it's more visually interesting. And I think that our peers out there are the same way. But you already mentioned that it's easy to misdiagnose a patient. And so it's very unfortunately easy to assume that if it's all green, it's all good. And then we may mislabel somebody just because their scan came out red when it may not be bad at all. How do we navigate that challenge, and how do we educate our peers to navigate that?
Now, I think it's hard, right? Because I did a talk recently, and the name of the talk is called "Green Isn't Always Clean," and we polled the audience, and I think it's very like Pavlovian. You know what I'm saying? It's like we're so conditioned by these lights, and so the question I asked for the polling the audience was, true or false? It just kind of feels good when I see green. And I said, just be honest, like it's a completely, anonymous poll. And a lot of people were like, yeah, like, I mean, it's hard not to feel like, yeah, okay, this is legit. I'm feeling good. It's green. We have to just know that's the initial bias. We have to know, just like you said, these are probabilities and percentiles based on reference databases. You look at the Heidelberg reference database. It's called a U.S. ethnic mix, right?
Mm-hmm.
And so they have 330 patients. It's been around since 2016 when they got clearance on that. And then the breakdown is supposed to mimic what our demographics are, like a census-based demographics in the U.S.
Sure.
So you might have, 60% Caucasian. I mean, I have the actual numbers, but let's just play it out here. So 60% Caucasian, 20% Latinx, 15% Black or of African descent. And then there's an Asian group as well. And so you're trying to apply your one patient to that reference database, and then whatever number within that, and then you're doing probabilities. So, the green is 90%. So green's 95th percentile down to 5th percentile. And that's such a huge range of tissue that if we just go off how we're feeling, we're potentially going to get ourselves in trouble. Just like, when you see a red, it doesn't mean it's bad. So I just think, again, it's knowing that the color codes are percentiles and probabilities, and then also just knowing how our instruments work. So there's a range. It's called the dynamic range in our instruments that go from the top level of tissue that can be measured to the bottom level of tissue. And then when we acquire a scan, there's noise. It's not going to be exactly the same time, every time. So I think the noise in a spectralis is about 4 to 5 microns, depending on what I cite you. And so if I'm just throwing numbers out here, let's say the 95th percentile is 105 microns and the 5th percentile is 70 microns. And our change could be 5 microns for it to actually be a legitimate change. That's 6 or 7 changes of 5 microns within the green. And that's potentially scary. I mean, there's data out there that depending on the size of an axon, 5 microns could be 141,000 axons. So that's a ton of tissue that could be lost in the green. So I think it's number one, trying to remove ourselves from what we've been conditioned for years on, having to provide ourselves perspective, and then try to just be flexible and just see what happens over time. And that's
Sure.
pretty much it.
So on that note, let's say we're talking about an existing patient, a patient that you have a longitudinal array of scans to look at. how more valuable is it to you to look at issues that alter over time versus isolations in time?
Yeah,
Isolated.
it's a great question. So I don't know if our listeners or your listeners have heard of the rule of five. There's this rule of five that came out, and it was loosely applied where it took the machine noise into consideration. So again, as I said before, so today we do a scan on 5/23/2024, and then we do another one on August 23rd, 2024. And if the overall average changes by 5 microns on that next event, then we can say, whoa, that might be clinically significant. Maybe we should consider escalating treatment or initiating treatment for the first place, depending on the scenario. And what they've shown is that using trends over time is more accurate than just making a decision on one event that supposedly exceeds the acquisition noise. And I think the false positives, it was like a pretty high rate of false positives, like 25 or 30% false positives if we just use the one piece of information. So you're better off making decisions at the rate of progression on a trend. But that also leads to problems. If all you're doing is looking at trends, you might miss events, and those events might actually be impactful. So you got to really look at all of it overall. But it requires multiple data points to make a decision. I think the biggest mistake I used to make, and I don't know if you used to make this when you were younger, was feeling like there's urgency. Mm-hmm. So it's like, okay, there's a change here, and I don't want this person to lose vision, so I'm going to intervene without sitting back and confirming that there's actually a legitimate change here that actually can back up what I'm doing, because it's a big decision.
Agreed. Yeah. I mean, when we're talking about a condition like glaucoma, they're being put on a chronic lifetime course of something, or a surgical intervention, both of which are serious.
Oh, absolutely. And you touched on it before, with the amount of dry eye work you do, and obviously getting your PhD in it with lid wiper. I mean, you're having all kinds of toxic effects from medications. I think that gets overblown a little bit, but it is a reality that you can have. You're putting someone that could be a polypharmacy on a glaucoma medication, and then potentially more medications. It doesn't really breed good adherence for our patients.
So we're at red, yellow, and green again. You have maybe now a color change. So besides the micron issue, you have a patient who was seen 5 months ago that was yellow and now they're red, or they were green and now they're yellow. How much does that alter you, or your reflexes anyway, or your clinical decision making?
Yeah, I think that depends on how you're approaching it and what instrument you're working with. Some instruments will actually flag if there's a change in the color code. I'll be honest with you, once the patient has been diagnosed, I'm not looking at the color at all. I'm looking to see what's happening with the tissue thickness and seeing if it's in excess of noise. If it's within noise, I'm looking at the fields. I'm looking at, how their overall quality of life is, burden of medications, burden of surgery, travel time. So I'm going to look at all that into my calculus and making a decision. And the OCT is a part of that. So yeah, if I have someone where the OCT numerically has changed, I'm looking at that number. I'm looking at that trend. I'm not even looking at the color. And I don't know if that's a fair enough question. I don't want to say completely disregard the colors, but at the same point, I pretty much don't look at the colors.
Got it. So you mentioned fields, because of course OCT, we're looking at form, field, we're looking at function. And one of the options that we have at our disposal with the Spectralis instrumentation is utilizing the hood report. Yeah. Could you just walk us through what exactly that means, and how often, if ever, do you employ it?
Yeah, so the hood report's great. So it's based on Don Hood up at Columbia. Don's done a ton of work and really has been a pioneer in trying to make sure we're maximizing how we use OCT, specifically because it's objective in topographical analysis of glaucoma. And I don't know that they've done a ton on progression, but what they've done is he takes, what they did initially, I forget which platform it was on. They took the disc data, they took the macular data, and they put it together in a one-page report. Because when we are fragmented as far as how we're trying to look at information. It makes it way more difficult. So they did a study a while ago just comparing one-page report analysis by glaucoma experts versus everything fragmented. And the analysis was much more consistent when they were using a one-page report. So the hood report combines the macular data and the disc data. And then it also will superimpose the visual fields on it. So we'll have a superimposed visual field loci for 10-2 as well as for 24-2. So I think that the only drawback is our grid on our 24-2 does not take into consideration retinal ganglion cell eccentricity. So what ends up happening is you have a more consistent grid in the real world versus the grid that's displayed on the hood report. So the grid that's displayed on the hood report still has the 54 points, but stretched out a little bit more through the central point. So you have two things. You have the topographical information and the color mapping and the deviation map, at least as far as what Heidelberg has. And then you have the superimposition of the field loci. So what you can theoretically do is if you're going to do a field, you can look topographically to see where the defect is, and you can see if your field's even going to sample that point. I mean, we have these wedges all the time where it's super likely that you're going to go ahead and miss it with the one light loci that's being shined down on the retina at that place. So you might shift over to doing a 10-2 or something like that, or 24-2C or whatever you have. Or you might expect that, hey, there's no way I had any shot of having a defect show up, or presumptively, I wouldn't have expected a defect to show up on the field based on what the OCT looked like in the first place, assuming we can presume it's accurate, or assuming it's accurate.
So you mentioned a 10-2 field. Is there anything on your Spectralis scan that would lead you, if you hadn't ordered it already, to say, time out, let me order a 10-2 because I'm not picking up anything on the 24 or 24-2C?
Yeah, there's a term, well, they have all kinds of terms for this. I mean, it's called the temporal Rafe sign. And so essentially, if you were to bisect the macula, with a horizontal line and separate into the, superior and inferior halves, what you would have is you would have a nice clean arcuate termination on the temporal side, kind of moving like this. So if you were to isolate the GCL, and really the recommendation is more to use the heat map than using the color map, because when you isolate GCL by itself, it doesn't have a huge dynamic range to work within. So you really kind of want to use, you're supposed to use total macular thickness on Spectralis. That's supposed to be the more powerful indicator. But I think we all look at isolated GCL, and isolated GCL is on the hood report. So I think if I had a arcuate pattern that was a temporal Rafe, they call it the Nautilus sign. Tony Litwack referred to it as the squeegee. Jim Williamson, who you had on last time, uses the Costa symbol because he loves his Costa sunglasses.
Right.
Anything that has a well-defined, well-delineated arcuate that's temporal to the fovea could spark your need to do a 10-2 if there was no other reason. And then you're doing more of a topographically guided approach versus just the willy-nilly approach that we did. I mean, back in like maybe 2015, I forget when it was when we all became obsessed with doing 10-2s. Right. And then we realized, wait a second, these really aren't doing anything near as what we were finding in the literature. And then Michael Sullivan and me came back and did some studies showing that, yeah, maybe if we looked topographically, it would make sense that you would get a 10-2 defect if you assumed it would be a 10-2 defect because you actually looked at the tissue. And I think he did that with residents, and he found that the residents were super accurate when they found a squeegee on an OCT, and then they did a 10-2 that topographically aligned. It's like, there's a shocker, versus just having this guesswork and all these different controversies of I do 10-2s and I do 20. Topographical approach, in my opinion, is the way to go. And really, any data-driven approach that's going to be consistent is ultimately going to be the way to go over the life of a disease.
Agreed. So this afternoon, when I'm back in patient care, if I see a patient who has been followed for some time as a glaucoma suspect, but nobody pulls the trigger, and I look at it and say, well, I would have treated this patient sooner, but I'm going to pull the trigger today. So long as it's POAG or time is on our side, most patients will be okay. I think the more complex question, which also occurs, is when I see a patient, perhaps this afternoon, who has been diagnosed with glaucoma, being treated for glaucoma. And when I look pre-treatment as well as today's data, I don't think the patient has glaucoma. That is a bit more challenging. Do you suggest we say time out here? I just disagree. Remove the patient from meds. There's some medical legal quandary here. What do we do with that? Or, I mean, because we probably don't want to continue a treatment that's unneeded. How do you suggest we tackle that challenge?
Yeah, I come back to where we are in healthcare is, when you and I graduated, we were still in that paternalistic approach where the patient would come in and we would say, you're going to do this. And they would say, yes, doctor, we really appreciate it. It's not how that works, and that's not even appropriate. So we work in a shared decision-making, sort of a situation now, right? So that's how we interact with our patients. So I think you have the conversation with the patient, because I think what used to happen when I was younger, like residency age or a little bit around that time, I was way more, bullheaded, and, I was still tall, but I looked younger. So I didn't have the same authority. And a lot of these patients have already been diagnosed with glaucoma, sometimes by people like us now who are older that maybe carry a little bit more authority, whether we should or not. I mean, there still has to be some legitimacy there. And the patient believes they have a disease and they have read up on the disease, and that disease is said to potentially blind them. And then
Right.
you come in and just say, hey, you don't have this disease. I've disagreed with all my colleagues, all this other stuff. It undermines, if we're over at the college, I mean, it undermines us. But it also confuses the patient. And if they have emotional burden already, that's not the best way to do it. So I had one last week where the patient was treated. And I'm telling you right now, the guy just doesn't have glaucoma. I saw each analysis flaw. I just sat down with him. And I have a slide deck that I've made up. That's a glaucoma patient education slide deck. I walked it through with him, and then I pulled up all his data, and then we went through it, and I said, hey, here's the situation. Okay. At this point, it really seems like there's no glaucoma that you have here. Again, maybe when you get older, it could happen, but I understand that you've been told already that you have glaucoma, and I understand that you might have some, fear of going blind from glaucoma. And I'm perfectly okay if you want to stay on medications, or if you want to digest, I'm not going to say digest to a patient, but if you want to digest this information and think about it, and then maybe we can take you off medications, and then we'll just watch you vigilantly, because I'm trying to get them tracked over to looking at the OCT and looking at the field and looking at the trends. And if I can show you that your trend is the same over the last 7 years, and that resonates with you, maybe you're more prone to do it. So I try to take a holistic approach with those, rather than coming in and trying to scorch the earth like I might have when I was younger, because I got burned on that a lot, and I was right a lot of the times. But they think they have something they're gonna go blind with.
Yeah, and if there's going to be some personalities that will nod their head and then leave you, never go back to see you again, and go someplace else to get the confirmation of what they think they have.
Yeah, it happened. It happened to me 3 or 4 times when I was in practice, and they ended up coming back. You know how it is in town. There's 4 or 5 practices that patients would jump between. I'd get them back, and they'd be back on medications. I'm just like, what are you thinking? But I get it now. I get it. And I've said this a long time, and people can disagree with me, but I think good clinical care and good patient management don't always align. And sometimes these patients, I will continue to overtreat them because they feel more comfortable. And that's just my personal take on it, depending on what the risks and benefits are for those patients.
I totally get it. So as we wrap up, you mentioned a number of times a data-driven approach to patient care, which I appreciate. So as we close, please give our listeners some last thoughts on how not to be confounded by colors to potentially avoid a missed or incorrect diagnosis, and how to go through our Spectralis high-tech scans the best way they possibly can, because pretty much everybody attending to this can change their behavior tomorrow.
Yeah, I think the main thing is assuming we're taking it from we matter as clinicians and our skill set and looking at the nerve matters, and we're taking it from that vantage point. Trust what you're seeing clinically, right? And then just know that the OCT is complementary to you from a diagnostic standpoint. And then the OCT is a tremendously powerful instrument for you to use to track the disease. Because really, when we look at the disease, we want to make sure we're catching our fast progressors. So look at the nerve, corroborate with the complementary information from a diagnostic standpoint. Don't have urgency in a lot of these cases, unless it really is. You'll know if the patient walks in. I always joke around, if you can literally see their chiasm when you're looking at the nerve and they're 50, okay, you don't have a lot of time to play with. But a lot of these POAG cases, I think maybe 10 to 12% of patients are fast progressors. Most of these patients don't require you to make a hair trigger response and start them on meds right away. Using the data-driven approach, you use your machine, you get good data, you confirm that the quality of the information is good at every visit, and then you track it over time. And really, what I love about the Heidelberg is you have all these tools at your disposal that allow you to manually change things, allow you to re-baseline, all these other things, so that you don't ever get lost. Because I think the deal is that we have so much information we're looking at these days. Sometimes it's much easier just to simplify off trend analysis, event analysis, and try to put everything together in one-page reports like Hood. And then we go from there. So you have all the tools at your disposal. I think Chris and I would both agree that this wasn't like some language that just came overnight to us. We spent a lot of time, and sometimes a lot of that time is after hours when your clinic is closed, just looking through things, listening to podcasts like this. Heidelberg has a website where there are a lot of tutorials on there. So it's just empowering yourself by getting better and not feeling like you are inadequate. If some of this stuff doesn't resonate right now, it will as you go on. So we can all do better for our patients, and we have the technology.
So last thing, my closing thoughts are: look at the patient first, look at their history first, look at the anatomy first, and like, as you, in your words, Drew, let this be confirmatory. You and I looked at an older scan yesterday that was entirely red everywhere.
Yeah.
And had we not taken a step back and said, well, this patient is a 20 Doppler myope, so the data, the analysis is challenged a bit, to say the least.
Yeah.
And really look at the scans, look at the anatomy, look at changes over time if this is an established patient, because as you said, the green isn't always clean. And conversely, red isn't always poor. We have to take everything within context. And if we do that, I think we can more aptly manage these patients.
Yeah, absolutely.
All right. Thank you again for being a guest today, Drew. And thank you all for attending to today's podcast. And please be on the lookout for more.
Class has ended for today, and we have no exams or grades approaching. Please email me at foureyeedprofessor@gmail.com if there are topics that you would like to hear and see through a professor's eyes.